OET English Test. Listening Test. This test has 3 parts. In each part you'll hear a number of different extracts. At the start of each extract, you'll hear this sound. You'll have time to read the questions before you hear each extract, and you'll hear each extract once only. Complete your answers as you listen. At the end of the test, you'll have 2 minutes to check your answers. Part A. In this part of the test, you'll hear 2 different extracts. In each extract, a health professional is talking to a patient. For questions 1 to 24, complete the notes with information you hear. Now, look at the notes for Extract 1. Extract 1. Questions 1 to 12. You hear a physician talking to a patient called Mr. Kevin Chamberlain. For questions 1 to 12, complete the notes with a word or short phrase. You now have 30 seconds to look at the notes.
Hello, doctor. Good afternoon. Good afternoon. May I know your problem? Well, doctor, I am a patient with coronary artery disease and peripheral vascular disease with prior stent-supported angioplasty. I'm having a persistent cough for the past 2 weeks and some shortness of breath. I was also treated for pneumonia. Do you feel any chest pain, pressure, or heaviness in chest? No, doctor. What's your age? 60, doctor. Do you smoke or drink? Well, I don't drink, but I'm a regular smoker. May I know your past medical history? Well, I have coronary artery disease since 2016, peripheral vascular disease for over 10 years, chronic obstructive pulmonary disease, and hypertension. Did you undergo any surgery in the past? Yes. Right fern popliteal bypass about 8 years ago, neck fusion in the remote past, stent-supported angioplasty to unknown vessel in the heart. What medications are you taking? Aspirin 81 mg daily, clopidogrel 75 mg daily, allopurinol 100 mg daily, levothyroxine 100 mcg a day, lisinopril 10 mg a day, metoprolol 25 mg a day, atorvastatin 10 mg daily. Are you allergic to any medicine? Yes, I cannot take aspirin because it is intolerant to my stomach. I get stomach upset. Okay, well, your physical examination result shows your body temperature is 97, heart rate of 90, blood pressure of 187 over 105. Cardiovascular studies show normal upstroke, distal pulse symmetrical. Heart regular with a normal S1 with normally split S2. There is an S4 at the apex. Lungs with decreased air entry. No wheezes. Echocardiogram shows mild biatrial enlargement, normal thickening of the left ventricle with mildly dilated ventricle, EF of 40%, mild mitral regurgitation, and diastolic dysfunction grade 2. Nuclear stress study shows fixed infralateral defects, no reversible ischemia identified. Laboratory data shows normal white cells, hemoglobin 11, BUN of 12.1, creatinine of 0.8, troponin of 0.04, BNP of 5700. Your premature ventricular contraction is random. You had runoff 3 beats consecutive 1 time. The patient denied any awareness of that or syncope. Did you have any temporary loss of consciousness related to insufficient blood flow to the brain? We term it as syncope. No, doctor. Actually, I'm unaware of it. Okay, you have cardiomyopathy, ischemic exacerbation of symptoms. Electrophysiology study is required for ventricular tachycardia. Defibrillator will be determined at a later stage. Continue with metoprolol with a little higher dose of 25 milligrams twice a day. Continue atorvastatin. Increase lisinopril to 20 milligrams daily to improve blood pressure management. Take hydralazine 50 milligrams for blood pressure management. Okay, thank you, doctor.
Extract 2. Questions 13 to 24. You hear an obstetrician talking to a patient called Vanessa Gordon. For questions 13 to 24, complete the notes with a word or short phrase. You now have 30 seconds to look at the notes.
So this first meeting, Mrs. Gordon, is mainly a chance for you and I to get to know each other. I'll ask about your medical history, and this is also an opportunity for you to ask me any questions that you've got at this point.
Sure.
So some background. What kind of work do you do?
I have a job at an engineering company. I'm a computer programmer. I currently do 4 days a week, but I hope to reduce that to 3 after my maternity leave.
Ah, excellent. So tell me about your medical health. Do you have any conditions I should know about?
Well, I have asthma attacks, but they don't happen often. I lost about 10 kilos, and that certainly helped. I have an inhaler, but I hardly ever use it. Oh, I should also let you know that I come out in terrible hives if I take penicillin, but not other things. I'm fine if I eat nuts, for example. I have a fairly healthy lifestyle. I'm a vegetarian and I've never smoked.
Good.
I'm afraid I don't go to the gym or anything, but I walk to work and generally keep active.
Oh, that's good. So this is your first pregnancy?
No, I have a daughter called Ella. She's 3 now.
Ah, and did everything go smoothly that time?
There were no major problems during the pregnancy itself, but it took me quite a time to fall pregnant the first time. After having various tests, I was given some fertility drugs. Oh, what were they called? It's on the tip of my tongue. Never mind, it'll come back to me. This time, though, I didn't need any help.
Oh, it's no problem. What about labour last time round?
Oh, that was a nightmare. Though everything, thank goodness, worked out in the end. It was a breech birth. It looked as if I might have to have a caesarean, and I really didn't want that. I was pleased I managed without an epidural, too. They had to use forceps to get Ella out, but I didn't need any stitches, so that was okay. Unfortunately, though, I had some difficulties after the birth, too. I was desperate to start breastfeeding, but that didn't work out. At least not until I was given some guidance by the midwife.
OK. So can I ask you about the baby's father?
Sure. That's my husband, Paul. There's something in his family history that I should tell you about, I think. His grandfather and father both had epilepsy, though he hasn't developed it himself. I'm not sure if that means his children have a greater chance of having it or not. Oh, also, he has a child from his first marriage, and she has Down syndrome, so he gets a bit anxious when I'm pregnant.
Oh, well, that's understandable, of course. We can discuss various testing options if you like. You might want to consider amniocentesis, for example.
But that carries a risk of miscarriage, doesn't it? I don't want to go for that. I've heard about another test called CVS. Is that something to consider?
Well, it's certainly an option. However, that procedure, in fact, also carries a small increase in the risk of miscarriage. And you'd need to come to a decision fairly soon, because it's normally carried out between weeks 10 and 12 of the pregnancy.
Well, I can tell you straight away that if there's more risk, then I wouldn't consider it. I know my husband will feel the same.
Well, that's fair enough. So, is there anything else you'd like to ask me about today?
Nothing urgent. But it'd be good to know more about how to get siblings ready for a new addition to the family. I want to make sure Ella doesn't feel threatened or replaced or anything.
Well, there's a leaflet that many parents find helpful. Here we are. Have a look through that.
Oh, thanks, that's great. I'm sure I'll have lots more questions at our next meeting.
Now look at Part B. Part B. In this part of the test, you'll hear 6 different extracts. In each extract, you'll hear people talking in a different healthcare setting. For questions 25 to 30, choose the answer A, B or C which fits best according to what you hear. You'll have time to read each question before you listen. Complete your answers as you listen. Now look at question 25. You hear a pharmacist talking to a patient. Now read the question.
Hi, I'm dropping off a new prescription.
No problem, I have this in stock, but I do notice that this prescription is from the hospital. Can you tell me more about that?
Yeah, I was in the hospital for about 10 days. I need my refills as they didn't give me any new prescriptions in the hospital.
I did have auto refills for you in the pharmacy. Unfortunately, I had to return it to stock since you weren't able to pick them up. But, if you give me 20 minutes, I can get them all ready for you.
I twisted my ankle leaving the apartment this morning. It's hurting real bad.
That's terrible, especially since it's your first day coming back from the hospital. But I did want to talk to you about one thing. The ibuprofen that you're holding, especially with your medical condition, will have a tendency to reduce blood flow to your kidneys.
Really? They told me I couldn't take Tylenol, but I thought that ibuprofen would be okay. At the hospital, they said my kidneys weren't doing too good when I first got there. But when I left, they said everything was back to normal.
Question 26. You hear a discussion between a nurse and a physician explaining about Nipah virus. Now read the question.
Hello, doctor. Can you explain what the Nipah virus is?
Well, Nipah virus is a member of the paramic severity genus Henipavirus. This Nipah virus was initially identified and isolated in 1999 during an outbreak of encephalitis and respiratory problems among pig farmers and other people with close contact with pigs in Singapore and Malaysia. The name of the virus originated from Sungai Nipah, a village in Malaysia where pig farmers became sick with encephalitis. Initially, the disease was linked with Hendra virus, emerged from bats, but was quickly singled out for investigation, and flying foxes of the genus were subsequently identified as the reservoir for the Nipah virus.
Question 27. You hear a radiographer talking to a patient about her MRI scan. Now read the question.
Come in, Mrs. Brown, isn't it? My name's Ted, and I'm going to be doing your MRI scan today. Now, can you get up on the table for me?
You know, I'm really claustrophobic.
Well, this is a new piece of equipment. The diameter is much larger, so it should make it a little more comfortable for you. You'll also have this call bell, so if you need me at any point during the test, you squeeze that, okay?
Okay.
Now, your scan's only going to take about 15 minutes. Are you okay with that?
I am.
Okay, let's get started then.
Question 28. You hear a nurse reporting to the doctor regarding a patient. Now read the question.
Hi, Dr. Walker. Yes, this is Carolyn Hall. I'm calling concerning Virginia Woolf in 347B. She's a para 1, gravida 1, and she has a massive amount of bleeding that saturated her bed and is pooling on the floor. Yes, and right now she's unresponsive and her blood pressure is 86/40. Her heart rate is 122, her respirations is 12, and her O2 sat is 90% on room air. Yes, she had an uncomplicated vaginal delivery this morning, and we gave her some Percocet and Ambien about 90 minutes ago. She has a saline lock on in her right arm, and it looks like a hemorrhage, and I think you should come and assess the patient.
Question 29. You hear a pharmacist talking to a doctor about a patient's medication. Now read the question.
Sorry to bother you, Dr. Anderson. I just wanted a quick word about Mrs. Campbell's prescription. The one for diphenhydramine that you gave her last week.
Ah, yes, for her allergies.
Yeah, so she's been taking 50 milligram tablets for about a week now. The thing is, she's just been into the pharmacy and she says that the tablets are making her feel really drowsy and her mouth's really dry, ever since she started on the pills.
Really? Well, that does happen from time to time. But maybe switching her onto a different medication wouldn't be a bad idea.
Okay, I'll look into some options and then run them past you later, shall I?
Fine, thanks.
Question 30. You hear two doctors doing an activity at a staff training day. Now read the question.
So, what did the trainer say we have to do?
Well, we've got to look through these case notes, 10 sets in total, and decide which of the patients should be referred to the consultant as a matter of urgency and which can wait.
Oh, right. And did I hear him say there's a limited number you can refer?
Not exactly. He said that we should put them in rank order according to the severity of the symptoms and other factors evident from the case notes. Once we've agreed on our list, we have to go and compare with another pair of trainees.
Okay. Let's get started then.
That is the end of Part B. Now look at Part C. Part C. In this part of the test, you'll hear two different extracts. In each extract, you'll hear health professionals talking about aspects of their work. For questions 31 to 42, choose the answer A, B or C which fits best according to what you hear. Complete your answers as you listen. Now look at Extract 1. Extract 1. Questions 31 to 36. You hear a geriatrician called Dr. Claire Cox, giving a presentation on the subject of end-of-life care for people with dementia. You now have 90 seconds to read questions 31 to 36.
My name's Dr. Claire Cox. I'm a geriatrician specialising in palliative care. My topic today is an increasingly important issue: end-of-life care for dementia patients. The care of dementia patients presents certain problems. Dementia is a terminal illness and is the third highest cause of death in Australia. Different from other such conditions, It has an unpredictable trajectory, and there can be difficult issues around patients' mental capacity, decision-making and communication. But, in spite of an equal need for palliative care services, dementia patients don't always fit the traditional model of such care. Families often suffer distress because they feel unable to ensure that their loved one's wishes are being respected, or just don't know what that person wanted because the discussion wasn't held early enough. There is therefore a clear need for well-funded, patient-centred palliative dementia care that's available when and where it's needed. I do a lot of work with Dementia Australia, an organisation which represents the needs of Australians living with all types of dementia, and of their families and carers. It also campaigns on dementia issues and funds research. Dementia Australia decided it was the right time to examine the issue of end-of-life dementia care from the perspective of the consumer as well as from that of the healthcare professional. It's a timely initiative. We have plenty of anecdotal evidence but not enough hard facts about what's going wrong and why the system's failing. But the current situation isn't all bad. Despite the issues I've mentioned, I've heard some wonderful examples of how it has made a big difference to people's lives. Things can obviously go badly wrong if this isn't handled well. But in the right circumstances, people with dementia can reach the end of their lives peacefully and with dignity. Dementia Australia commissioned researchers to conduct a survey on the end-of-life issues affecting dementia patients. The survey covered both care professionals, that's doctors, nurses and others working with dementia patients, as well as family member carers. The interest was overwhelming with more than 1,000 responses from around Australia. But what do the results tell us? Well, the initial results confirmed what we've heard about access to appropriate end-of-life care. It was obvious immediately that there was a between the perceptions of care professionals and family member carers about end-of-life dementia care. For instance, while 58% of family member carers said that they didn't have access to palliative care specialists and 68% didn't have access to hospices, 3/4 of care professionals indicated that people with dementia in their area do in fact have access to palliative care. This begs the question of whether consumers, that is patients and family member carers, might not be aware of services that are available. Another notable finding of the survey was that care professionals often lack knowledge of the legal issues surrounding end-of-life care. Some reports indicate that care professionals are at times reluctant to use pain medications, such as morphine, because of concerns about hastening a patient's death. However, access to appropriate pain relief is considered to be a fundamental human right, even if death is earlier as a secondary effect of medication. Our survey found that 27% of care professionals were unsure about this, or didn't believe that patients are legally entitled to adequate pain control, if it might hasten death. So perhaps it isn't surprising then that 1/4 of former family member carers felt that pain wasn't adequate. This lack of awareness extends beyond pain management. The statistics on refusing treatment were particular. Almost 1/3 of care professionals were unaware that people have the right to refuse food and hydration, and 1 in 10 also thought refusal of antibiotics wasn't an option for patients in end-of-life care. How can we ever achieve consumer empowerment and consumer-directed care if the professionals are so ill-informed? There's a clear need for greater information and training on patients' rights. Yet over 1/3 of care professionals said they hadn't received any such training at all. It's obvious that end-of-life care planning is desirable. Discussing and documenting preferences is clearly the best way of minimising the burden of decision-making on carers and ensuring patients' wishes are respected. Advanced care planning is essentially an insurance policy that helps to protect our patients in case they lose their decision-making capacity. Even though a patient might believe that loved ones will have their best interests at heart, the evidence shows that such people aren't that good at knowing what decisions those they love would make on complex matters such as infection control and hydration. So before I go on to...
Now look at Extract 2. Extract 2. Questions 37 to 42. You hear the lecture given by a Dr. Aaron Broderick on the topic blood type classifications. You now have 90 seconds to read questions 37 to 42.
The human body contains about 10 pints of blood depending on the size of the individual. However, the blood composition is not the same in each individual. This is what makes the different blood types. The best method of grouping of blood is the ABO system, although there are other groups. Within the ABO group, there are 4 major categories that are divided into 8 common blood types: A, B, O, and AB. Blood consists of cells and a yellow liquid known as plasma. The group of blood depends on what each part of the blood contains. There are 2 main blood group systems: ABO antigens and rhesus antigens. These 2 antigens are used to classify blood types. Normally, viruses and bacteria carry an antigen. During an infection, the antigen marks them as a foreign substance to the body that are usually not found in the body. Most red blood cell antigens are protein molecules on the surface of red blood cells. White blood cells produce antibodies as an immune defense. These antibodies target antigens and attack the foreign substance. Cross-matching of blood types is very crucial because if a patient receives red blood cells with antigens that is not present in his body, then it will reject and attack the new red blood cells. The ABO blood grouping method is used to determine the different types of antigens in the red blood cells and antibodies in the plasma. This system and RHD antigen status determine the blood type that will match for a safe red blood cell transfusion. There are 4 ABO groups. In Group A, the surface of the red blood cells contains A antigen, and the plasma has anti-B antibody that would attack any foreign B antigen containing red blood cells. In Group B, the surface of the red blood cells contains B antigen, and the plasma has anti-A antibody that would attack any foreign A antigen containing red blood cells. In Group AB, the red blood cells have both A and B antigens, but the plasma does not contain anti-A or anti-B antibodies. Patients with type AB can receive any ABO blood type. In Group O, the plasma contains both types of anti-A and anti-B antibodies, but the surface of the red blood cells does not contain any A or B antigens. Having none of these A or B antigens means that they can be safely transfused to a person with any ABO blood type. Some red blood cells contain the Rh factor, which is also called Rhd antigen. Therefore, rhesus grouping adds another dimension. In case the red blood cells contain the Rhd antigen, they are Rhd positive. If they do not contain Rhd antigen, they are Rhd negative. That means there are 8 major blood types in the ABO/Rhd blood grouping system. For instance, in the US, 30% population are A positive, A plus. A negative occurs in 6% of people. There are only 9% of population with B positive, while B negative occurs in just 2% of the population. AB positive occurs in 4% of people, and AB negative occurs in just 1% of people. O positive occurs in 39% of people, while O negative occurs in just 9% of people. About 82% of the U.S. population has Rhd positive blood. O negative blood contains neither A or B or Rhd antigens. Therefore, these red blood cells can be transfused to nearly all patients of any blood type. Group O negative is considered as the universal donor type. On the other hand, AB positive blood contains no anti-A or anti-B or Rhd antibodies. Therefore, patients with this blood type can receive nearly any type of red blood cell transfusion. This type is referred to as the universal recipient type. In case a patient with group B antigen receives red blood cells from a person with group A antigen, their body will reject the transfusion. This is because patients with B antigen on their red blood cells have anti-A antibody in their plasma. The anti-A antibody in the plasma then attacks and destroys the A antigen donor red blood cells. During pregnancy, a mother may have a different Rhd type to the fetus, as the fetus can inherit a different blood group from the genes of the father. Therefore, a risk is involved if the mother is Rhd negative and the fetus is Rhd positive. A small amount of red blood cells from the fetus can enter the mother's bloodstream, resulting in creation of anti-Rhd antibody in the plasma by the mother, which is known as sensitization. A problem will arise if this antibody then detects the foreign antigen in the blood cells of the fetus, and if they attack the red blood cells of the fetus as a defense mechanism, which can result in severe jaundice and brain damage if undetected. Therefore, an injection of anti-D immunoglobulin G helps to prevent the production of this antibody in the mother and decrease the impact of a sensitizing event on the fetus. Anti-D immunoglobulin G dosing is usually given at 24 weeks of the pregnancy and at times an additional dose during 34 weeks of pregnancy. The effect of anti-D immunoglobulin G lasts up to 12 weeks. During blood test procedure, the patient's blood will be mixed with a variety of serum samples. Each serum sample consists of a different blood type, with the clotting agent removed. Then, the reaction of the blood sample of the patient with the serum sample will be monitored. The antibodies in the serum will cause a different reaction in each one. For instance, if a reaction occurs when the blood sample is mixed with the serum consisting of blood type A, which contains anti-B antibody, the unknown blood type of the patient must be type B.
That is the end of Part C. You now have 2 minutes to check your answers.